Welcome to the 5th annual conference and Mental Health and Hope. I am Denise Loeb, and I am the president and founder of Just Ask. And I am a stroke survivor had a TBI too, and I am living with aphasia, or they're living with me. We have been doing our conference for 5 years now, and I started this due to the fact that I needed to know more information about this thing called aphasia, and I couldn't find as much as I wanted. So started the conference, and I didn't think anybody should have to get paid to learn more about their own disability. So I am very thankful and proud with the people that support us that we are able to continue not to charge any fee for our program. And without the help from Rhode Island Department of Health for sponsoring us, this couldn't be able. And we are so thankful that the National Aphasia Association has also sponsored us this year. One of the additional things that we've been able to do 2 years in a row now is to provide CEUs for professionals. In order for this to happen this year, we had CEUs facilitated by CareLink and RISHA. And that information will be provided for you to contact them to get your CEUs and the information. The link is there. Where am I? Again, we talked about housekeeping. We will be recording it. Thank you, Ben, for covering all of that for me. I'm trying to read, so be patient with me. Chat box will be read by somebody else. Next week, we will be having our last Saturday session. Please note the change will be at 1 p.m., not 9 a.m. Eastern time. We do have our guest speaker, Deb Meyerson, Stroke Onward, and identity theft writer. She's the author of that book. And without any other delays, I am going to forward this to Melissa, who is one of the stroke coordinators here in Rhode Island. And I want to say thank you, because they were the ones that first sponsored us in our conference. And without them kind of encouraging and pushing me forward to do this, I don't think I would have been here. So thank you, all the stroke coordinators, for continuing to support those with aphasia. Here you go, Melissa, it's all yours.
Good morning, everyone. First off, thank you to Denise and the Just Ask Foundation for inviting us to do this presentation for you. My name is Melissa. I'm the stroke program manager at the Comprehensive Stroke Program at Rhode Island Hospital. On here as well is Karen Schaefer, who is the program manager for the Miriam Hospital and Newport Hospital. Karen and I, along with Stephanie, who's the assistant clinical manager for the program at Rhode Island, put this presentation together for you. There'll be more introductions in it, so I'm not going to go too far into them. It is on a video, so you might have to turn your volume up a little bit, but I hope you enjoy it. My camera's going to be off. I'm dealing with a cold. You don't need to see me dealing with that. So I'll be here, and Karen and I will both be back for the Q&A. So we'll see you then.
Good morning, and thank you for having us here today to speak at the 5th Annual Aphasia Awareness Conference. My name is Karen Schaefer. I am the Stroke Program Manager at Miriam Hospital and Newport Hospitals. Today I am here with Melissa Harmon, the Clinical Manager of the Stroke Program at Rhode Island Hospital, and Stephanie Souza, the Assistant Clinical Manager of the Stroke Program at Rhode Island Hospital. Together today, we will be talking about brain injury and mental health. What's the connection? Melissa, Stephanie, and myself are also members of the Rhode Island Stroke Coordinators Network. The Rhode Island Stroke Coordinators Network is a group that was established in 2004 as a means to share the best practices among health professionals across Rhode Island. So let's get started. First, I'm going to talk about anatomy of the brain. First, let's talk about the structures of the brain. The brain can be divided into three sections. The forebrain, which you see here in purple, the midbrain, which is the section in blue, and the hindbrain, which is the section in yellow. First, I'm going to talk about the hindbrain. The hindbrain is the upper part of the spinal cord, the brainstem, and the cerebellum. This area of the brain controls all of the body's vital functions such as respiration and heart rate. It coordinates the movements of your body. Examples of when you're using your hindbrain are when you're playing the piano or you're hitting a baseball. Midbrain is the part you see here that's blue. This is the uppermost part of the brainstem. This part of your brain controls some of your reflex actions, such as controlling your eye movements, as well as other voluntary movements of your body. And the third section of your brain is the forebrain. That's the section you see here in purple. The forebrain is the largest and most highly developed part of your brain. This part of your brain is responsible for receiving and processing sensory information, thinking. It's where, when you're hearing language, you understand language. It's where you speak. And it also has to do with your motor functions of your body. Next, I will talk about hemispheres of the brain. Each hemisphere of the brain can be divided into sections or lobes. Each lobe specializes in different functions. I will talk briefly about each lobe and its function. When you have an injury or a stroke to a particular part of the brain, the function of that area of the brain is what will be affected. Now, frontal lobes is the part next to the star here in orange. You have two frontal lobes, and they are positioned directly behind your forehead. This part of your brain is used for planning, imagining. It's also where you have arguments. This part of your brain acts as a short-term storage area for your thought, which is the area here in blue, is the area of your brain that helps you plan, control, and execute voluntary movement of your body. An example would be moving your arm to pick up the phone, pick up something to drink, or kicking a ball. Your somatosensory cortex, which is the part in purple, is the part of your brain that receives information about temperature, taste, touch, and movement for the rest of the body. Your parietal lobes is indicated here in green, and your parietal lobes are responsible for reading and arithmetic. When you eat, this lobe also allows you to taste, smell, and feel the texture of the food that you're eating. Your occipital lobes is here in red, and your occipital lobes are responsible for vision. And what this lobe does is it processes the images from your eyes and then links these images to a memory. This is how you recognize objects when you see them. Your temporal lobes, which is here in magenta, is where you receive information from your ears. And this area of your brain forms and retrieves memories, including things such as taste, sight, and touch. This is also the part of your brain that recognizes music. When you hear a song and you realize that you have heard it before, it's how your brain will tell you what song it is or what composer you are listening to. So now let's talk about what a traumatic brain injury is. And a traumatic brain injury, also known as TBI, is caused by a forceful jolt, a bump, or a blow to your head. A traumatic brain injury can be caused by objects that pierce your skull and enter your brain. And there's two broad types of traumatic brain injuries. They're called penetrating and non-penetrating. A penetrating TBI is also known as an open TBI, and this occurs when an object pierces the skull and enters the brain tissue. Penetrating traumatic brain injuries typically damage only the part of the brain that's affected, that's touched. For example, if a bullet goes through your skull into your brain, the part of your brain that's affected is where the bullet touched. A non-penetrating traumatic brain injury, which is also known as a closed head injury or blunt TBI, is caused by an external force that's strong enough to move the brain within the skull. For an example, a car accident, a sports injury, or something hitting your head like a baseball bat. When these non-penetrating injuries happen, the force, the blow, actually causes the brain to shift and bounce off the inside areas of the skull. So what are signs and symptoms of a traumatic brain injury? You can see here there's a lot of different symptoms. They can be physical symptoms such as a headache. Someone could have convulsions. They could have vision changes such as blurred vision or double vision. They could have pupils that are unequal size. One pupil could be more dilated or more constricted than the other. You can have clear fluid that drains from the nose or the ears. You could suddenly be nauseous and vomiting. And you could have other neurological deficits such as slurred speech, weakness of the arms, weakness of your legs. You could have a facial droop. You could have a loss of balance. Many symptoms of a TBI can be similar to that of a stroke. I'm sure many of you know that slurred speech, weakness of arms or legs, and loss of balance are also symptoms of a stroke. Other signs and symptoms of a traumatic brain injury can be a cognitive or behavioral change. The patient can suddenly have a loss or change in consciousness. They can have a decreased level of consciousness. They could suddenly be very lethargic or obtunded, and they're very difficult to awaken. They can be confused, not know where they are, not able to name objects or the month. They can have problems with their memory. They could have problems concentrating. They're trying to do a task and they can't finish the task because they can't concentrate to complete the task. They can have difficulty with decision making, not sure which of two objects they want to choose. People with TBIs can have changes in their sleep pattern. They could sleep more, they can sleep less. They could be very easily frustrated or very easily irritable. The patient can experience changes in perception. These are other signs and symptoms of a traumatic brain injury. The patient could have lightheadedness, dizziness, vertigo. They could have blurred vision. They could have a ringing in their ears. They could have a bad taste in their mouth. They could be sensitive to light or sounds. They have mood changes. They could be fatigued. Symptoms such as headache, dizziness, confusion, and fatigue tend to start immediately after the injury but can resolve over time. The emotional symptoms such as frustration and irritability tend to develop more during the time of recovery. It's important to know that if somebody has an injury to their head, they should seek medical attention. And they should also seek emergency medical care if they experience any of these signs and symptoms after they had an injury to their head. So who is likely to get a traumatic brain injury? Adults over 65 are at the greatest risk for being hospitalized from a traumatic brain injury. Typically, this age range
experiences their traumatic brain injury from a fall. But overall, traumatic brain injury rates are higher in men than they are in women. Men are more likely to be hospitalized from a head injury, as well as 3 times more likely to die from a head injury than a woman. So what are the leading causes of traumatic brain injury? Falls. Falls is the most common cause of a traumatic brain injury. These are most frequently seen in the youngest and the oldest age groups. Blunt trauma to the head or blunt trauma accidents is when the person is struck by another object. This can include sports-related injuries, assaults, anytime something is thrown at the head or struck into the head. Vehicle-related injuries includes when someone is struck by another motor vehicle as well as being in a motor vehicle accident. In these accidents, the head can actually hit in the car, causing the traumatic injury. Assaults and violence, these are abuse-related traumatic brain injuries, and this includes domestic violence, shaken baby syndrome, or gunshot wounds to the head. And explosions or blast injuries is a common traumatic brain injury to military service members. A majority of these are classified as mild head injuries. A traumatic brain injury is injury to the actual structure of the brain. It's a very complex process after the initial injury that ultimately results in the loss of cell function, and it can lead to potential death of the cell. The injury to the brain can cause things such as edema, spasms within the brain. It can cause increased pressure within the brain. The brain may not get enough oxygen, it may not get enough glucose, and these things together can lead to cell death.
Good morning. My name is Melissa. I'm the program manager at the Comprehensive Stroke Center at Rhode Island Hospital, and I'll be picking up the presentation from here. Let's switch gears and talk about what mental health and mental illness is. Mental illness was in the news when well-known stroke survivor, Senator John Fetterman, checked into the hospital for post-stroke depression. Many articles I saw and quotes I read from other senators were concerning in that a question was raised as to whether Senator Fetterman was still competent to carry out his duties as an elected official. Not all mental illness diagnoses make someone incompetent to do their job, but it can present challenges to the individual and their caregivers. As we will discuss, a brain injury, such as stroke or a traumatic brain injury, put patients at increased risk for mental illness. The effects, coping, and treatment of mental illness are very individual experiences, and we hope to provide information so patients and caregivers can be aware of what to watch for and what they can do to help. As we talk about mental health and mental illness, I think it's important to remember that in our daily lives, we are going to experience a range of emotions, from happiness to sadness to anger and frustration. And those are perfectly normal feelings to have. We're not going to be 100% happy all the time. We're not going to be dancing through this field of wildflowers with birds chirping in a blue sky. That's just not how life is. I think understanding the range of emotions that we feel, knowing what's normal for us personally, and then understanding when we're in a crisis all helps to set a framework for healthy mental health and awareness of mental illness. Let's talk about what mental health is. These are CDC definitions, and I think it's a good outline for how we should think about what mental health is. It's part of our overall health, just like our physical health. I think sometimes people forget about that, because when you are looking at someone and you see that they have a cast on their leg, you may think, oh, that poor person's feeling pain or they're uncomfortable, but sometimes we don't think about what is going on emotionally with them. And that can be very important, because our mental health plays into how we heal, how we cope, and how we live the rest of our life. A poor mental health and poor mental illness are not the same, though. So I think that's also important to keep in mind. We can go through periods of our life where perhaps we don't feel so good, things are very stressful, we might feel a little depressed, but it may not necessarily meet the criteria for a clinical diagnosis of mental illness. And on the other side, we know that people who have depression can portray being happy or coping well when really behind the scenes they're not dealing very well with things at all. Mental health is often underreported, underdiagnosed, and misunderstood. And I think this is something that's important to keep in mind as a patient and a caregiver, that we need to be an advocate for the mental health of ourselves and our family and friends. This slide just shows all the different types of mental health or mental illness disorders that there are. As you can see, they get pretty detailed. And just because you have one mental illness does not mean you don't have another. They are not mutually exclusive. So sometimes it can be difficult to differentiate what a patient is going through because there are several layers of mental illness going on top of other comorbidities or conditions that the patient has. This is a good list of some personality symptoms that can be experienced by a patient after having a brain injury. Many times when I'm following up with my post-stroke patients, either the patient, family, or a friend will express concerns about personality changes that are ongoing. It's normal to have some personality changes after an injury. The question becomes, are they permanent? Are they going to get better, stay the same, or get worse? These symptoms can be intensified by injury or stress. So that's important to keep in mind that as the patient goes through the healing process, these symptoms can wax and wane and get more intense or less intense. It's always important to keep these symptoms in mind, as if they start to become obtrusive to your normal life or very impactful to life, they need to be brought up to the attention of your doctor. Pain is not on this list, but it can also affect your mental health and well-being. As we know, everyone perceives pain differently, and pain can affect how we cope and heal. So that's important to keep in mind. On the next slide is a video about post-stroke personality changes, and I think you should find it very enlightening.
A stroke changes life for the survivor and everyone involved. Not only do survivors experience physical changes, but many experience personality changes. Personality refers to specific patterns of behavior, thinking, and emotions. Your personality can change and vary greatly after a stroke, depending on what part of the brain is affected and the severity of the injury. Personality changes may upset survivors and caregivers, and often negatively influence a person's quality of life. Common personality changes may include impulsiveness, apathy, pseudobulbar affect, depression, anxiety, anger, irritability and aggression, confusion and denial, forgetfulness, and fatigue. Let's learn more about each of these personality changes. Stroke survivors may be unable to control their anger or become irritable. For example, they can easily anger at a family member over a trivial matter. In some cases, survivors can show aggressive behaviors, including hitting or hurting others, kicking, biting, grabbing, pushing, or throwing objects. In addition, their verbal behavior may include cursing, screaming, making noises, or hostile muttering. This personality change is present in 15 to 35% of stroke survivors. Depression is a common and serious complication after a stroke, experienced by about 30% of stroke survivors. Depression can occur right away, months, or even years after a stroke. Symptoms of depression may include fatigue, apathy, loss of interest, and decreased concentration. Memory loss is caused by the damage of nerve cells in the brain. Each side of the brain controls different functions. A stroke on one side of the brain will cause separate problems than the stroke on the other side. This means that memory loss will not be the same for each stroke survivor. Two types of memory that can be affected by stroke include verbal and visual memory. Memories of names, stories, and information having to do with words is known as verbal memory. Memories of faces, shapes, routes, and things seen is known as visual memory. About 20% of stroke survivors experience anxiety at some point after stroke. Anxiety is closely associated with depression. Signs of anxiety may include excessive worry, extreme or unreasonable fear, difficulty managing daily tasks, heart palpitations and shortness of breath, and feeling of losing control. Other times, anxiety can express itself through isolation from family and friends and avoiding activities. Apathy following stroke is estimated in 20 to 25% of survivors. It's often associated with depression and problems with thinking. Survivors who suffer from apathy tend to have a harder time recovering after stroke. Pseudobulbar affect, or PBA, is a medical condition that causes sudden and unpredictable episodes of crying or laughing, often in socially inappropriate situations. Occurrence of PBA has been reported in 6 to 34% of stroke survivors and is more common in women. PBA may have a negative impact on a stroke survivor's relationships, leading to isolation, intense depression, and anxiety. Impulsiveness is described as the inability to think ahead or understand consequences. It's more common in stroke survivors with right side or a frontal lobe stroke. Post-stroke fatigue affects 23 to 75% of stroke survivors. Symptoms of fatigue may include exhaustion, weariness, and lack of energy. It's not uncommon for survivors to experience all of these personality changes. Screening for and identifying emotional, behavioral, and cognitive changes after stroke is important because they are often treatable. Proper management may also improve survivors' quality of life. However, these conditions are not always apparent and often go unnoticed, even by healthcare professionals. For depression and anxiety, one of the best treatments is counseling or therapy with a licensed mental health professional. Family members should encourage their loved ones to get assessed. To restore functioning and independence after stroke, rehabilitation therapy can be beneficial. It can improve the survivor's quality of life and help them participate in society. For example, some therapies can help the survivor practice skills over and over so they can improve. Other therapies will provide survivors with alternative approaches for completing daily activities despite cognitive loss. This can include the use of assistive devices that help with speech, tactics for remembering your grocery list, and calendar and memory tools. Stroke survivors can also benefit from cognitive behavioral therapy. This treatment helps the survivor examine relationships between thoughts, feelings, and behavior. Post-stroke personality changes are challenging, but rehabilitation and therapy can help improve your recovery. Focus on what you can do. Use your mind and body as much as you can. And remember that most things improve over time. Surround yourself with family and friends who love and encourage you. It will be easier to stay motivated and inspired to work towards your greater independence.
Mental health is very complex, and even if a patient is coping at this minute, doesn't mean that in the future they're not at risk of developing a mental illness. So that's something to keep in mind and something to keep an eye out for, especially since an adverse life experience such as a brain injury can increase these mental health risks. And it's so difficult with mental health because you can end up in this vicious circle. As we know, a brain injury can lead to some chronic condition sometimes, or maybe there was a chronic condition to start with. Well, that increases your risk of mental illness. And mental illness like depression can increase your chances of a chronic condition. And you just kind of keep going around in this loop. So it's important to break this cycle, to put in coping, and to recognize when a crisis is happening. This slide goes over some of the mental health stats. In the general population, mental health illness is more prevalent than I think what most people realize. A lot of Americans get diagnosed with mental health or experience an illness every year, and then 1 in 25 live with a serious mental health disorder. Going over to the brain injury side, this says stroke, but we can extrapolate that to brain injury patients in general, where you can see increased risks of depression, anxiety, fatigue, and emotionalism. And unfortunately, after the post-acute period, patients sometimes continue to have these symptoms and these illnesses that they have to deal with. We'll talk a little bit about emotionalism on the next slide and explain what it is. This is the definition of emotionalism, and I draw a parallel line between emotionalism and some of the personality changes I discussed earlier. In speaking with post-brain injury patients, their family, or their friends, sometimes they will ask about those personality changes along with some of these changes that fall under emotionalism. And they have a similar origin in the injury to the structure of the brain has caused a sort of malfunction into the centering of these emotions and the handling of these emotions. Knowing that patients who've had a brain injury are at an increased risk of mental illness, I've included a list of possible early warning signs. Please remember, this is just a general guideline. Signs and symptoms can vary between patients, and what's okay for one patient may not be okay for another. Next, we're going to watch a quick video on post-stroke depression, and I hope that helps aid your knowledge in mental illness and depression.
Depression is a common and serious complication after a stroke. It's largely unrecognized, underdiagnosed, and undertreated. Depression can result from a biochemical change in the brain due to stroke or from an emotional reaction to one. About 30% of stroke survivors develop depression. It can occur right away, or months, or even years after a stroke. Depression may increase with stroke severity, but the processes underlying post-stroke depression are not completely understood. Post-stroke depression, or PSD, is a feeling of hopelessness that interferes with functioning. It's associated with higher death rate, poorer recovery, problems with thinking, such as inability to remember, learn new things, or concentrate, poor functional outcomes, and lower quality of life. Symptoms of post-stroke depression include depressed mood, called anhedonia, persistent sad, anxious, or empty feelings, significant fatigue or lack of energy, lack of motivation, withdrawal from family and friends, problems concentrating or remembering details, difficulty finding enjoyment in anything, sleep disturbances, irritability, an increase or decrease in appetite or change in eating patterns, feeling helplessness, hopelessness, or worthlessness, aches, pains, or digestive problems that don't get better with treatment, suicidal thoughts. Your healthcare professional should evaluate you for depression during a follow-up visit. Several factors can predict whether you're at risk of post-stroke depression. These include a history of depression, physical disability, stroke severity, cognitive impairment, previous stroke, a family history of psychiatric conditions, being a woman, a lack of family and social support after stroke, and anxiety after stroke. Stroke patients present unique challenges in identifying depression. Aphasia or other stroke-related neurological conditions may hinder depression's identification and treatment. There are a variety of screening tools available. It's important to include family members or caregivers in the evaluation process because symptoms of depression might not be easily identified by the stroke survivor. Patient education about stroke and the opportunity to talk about the impact of stroke on people's lives is very important. Because of the complexity of post-stroke depression, several treatments should be tried to determine if they're helpful specifically to you. Post-stroke depression can be treated. Treatments may include antidepressants, which should be closely monitored for their effectiveness. Antidepressants may help people enjoy life again. Psychotherapy, though it is not clear whether psychotherapy alone can help post-stroke depression. Examples of psychotherapy include cognitive behavioral therapy, motivational interviewing, and supportive psychosocial intervention. Patient education, counseling, and social support may all be added as components of a treatment plan. If you've been cleared to exercise, a structured exercise program for at least 4 weeks in addition to other treatment might also help treat your post-stroke depression. Finding a stroke support group can be beneficial. There you can connect with other stroke survivors and share your story. You can also learn of resources and services in your community to help make your post-stroke journey easier. Remember, if you have depression, talk to your healthcare professional. Be open and honest and explain what you're experiencing. Make it clear that what you're going through started after your stroke.
We've discussed what mental health and mental illness is. I want to take a quick look at how a brain injury physically affects the brain and subsequently affects mental health and illness in our patients. Our brains are highly complex organs that accommodate a lot of physiological functions, from our heart rate to the respiratory rate and our emotions and cognitive thinking. Any injury to the brain and its structures can impede the brain's ability to function. It also increases the risk of poor mental health, and it's been found injury to certain areas of the brain correlates to mental health illness. Studies show that damage to the brain can predispose someone to mental illness. This manifests differently based on the area of the brain that has been injured. There are a lot of complex terms and anatomy on this slide, and the point I'm trying to make is that the damage to the brain caused by trauma or stroke is complex. From the initial insult from injury to the body's response, there are many places where changes cause dysfunction in how the brain processes stimuli. As you can see from the last point, lesions due to a brain injury can be associated with an increased risk in mental illness, but the lack of a notable injury to an area does not exclude the possibility of mental illness happening. Healing is another step in this cascade of brain injury that we need to look at. Although we all think of healing as a good thing, sometimes the body's response to injury can actually further insult what's already been done. I like this quote because I think it's a great explanation about healing. And one of the big words in the front there is neuroplasticity. And I just want to explain that as being the ability of the brain to form and reorganize synaptic connections, especially in response to learning or experience or following an injury. So what this is basically the remapping of the synaptic connections in the brain while you learn, while you're having an experience or following an injury. And basically what the statement says, even though this refers to stroke, the principle can be carried over to any brain injury. And this speaks to the complex process I previously mentioned that occurs immediately after the injury and throughout the healing process. What cognitive and structural areas that were not damaged with the initial injury are at risk during the later processes the body undergoes. Again, The take home is that the cascade unleashed by the initial injury puts the patient at an increased risk for mental health illness disorders. Next, we have a post-stroke pain video. And again, pain isn't necessarily listed as a mental health disorder, but pain itself can cause or further aggravate any mental illness or issues that are going on with the patient already.
A stroke occurs when normal blood supply to the brain is interrupted, preventing brain tissue from getting oxygen and nutrients. Pain is one of the most poorly understood complications after a stroke. It's also commonly underreported, underdiagnosed, and undertreated. Yet it's estimated to affect about 30 to 40% of stroke survivors. Patients often lack information about post-stroke pain and may stop treatment too early. General symptoms of post-stroke pain include numbness, tingling, burning, aching, decreased range of motion, and a change in skin color. Certain characteristics and behaviors have been identified as risk factors for developing post-stroke pain. Being a woman and having had a stroke at an older age. Alcohol use, statin use, depression, and peripheral vascular disease. Post-stroke conditions such as spasticity, reduced upper extremity movement, sensory deficits, and survivors of ischemic stroke. Let's take a look at the different types of post-stroke pain. Central post-stroke pain is a chronic painful condition that typically develops 3 to 6 months after a stroke and affects 7 to 8% of stroke survivors. It's a constant pain caused by an injured pain nerve and is described as a burning sensation or aching or shooting pains. The entire pain system acts as a nerve ending, and sometimes just a light touch can cause an intense episode. Headaches in stroke survivors are not well understood and can affect between 6 to 44% of stroke patients. Most are tension-type headaches, are moderate to severe, and can become chronic in nature. Spasticity is a common condition after a stroke, affecting 25 to 43% of survivors. Muscles can become stiff, tighten up, and resist stretching. This results in spontaneous, painful spasms and night cramps. Sometimes the muscle tone becomes so reduced that joints like an arm, hand, wrist, or toes get stuck in one position. This is known as contracture. About 60% of stroke patients experience contractures, which can make activities such as grooming, dressing, standing, and walking difficult. Shoulder pain may also be experienced after a stroke. During the first year, it can affect 1 to 22% of stroke survivors. Shoulder pain can interfere with recovery, slow rehabilitation, and cause significant distress. Diagnosis of post-stroke pain include clinical history and physical examination. Patients must report symptoms in 3 of the following 4 pain categories: increased sensitivity, skin color changes, asymmetrical sweating on different sides of the body, and decreased range of motion. They must also experience continuous pain on the affected side following stroke. Treatment of post-stroke pain includes several different options. Physical therapy can help stroke survivors relearn simple motor activities such as walking, sitting, standing, and lying down. Occupational therapy, which involves exercise and training, helps stroke survivors relearn everyday activities. This includes eating, drinking and swallowing, dressing, bathing, cooking, reading and writing, and using the toilet. The overall goal is greater independence. Botulinum toxin is an injectable treatment that temporarily relaxes stiff muscles after a stroke. Applying electrical currents through electrodes placed on the skin can reduce pain signals. This can include deep brain stimulation and motor cortex stimulation. Appropriate treatment depends on a number of factors, including the severity of the stroke and the type of pain experienced. Treating post-stroke pain with prescription medication has generally not been very effective. Their use should be tailored to the patient's needs, their response to therapy, and any side effects. Surgical treatment for survivors who have damaged nerves after a stroke can reduce their pain by 50% or more. The appropriate treatment depends on a number of factors, such as the severity of the stroke and the type of pain. The most important thing you can do if you experience post-stroke pain is talk with your healthcare professional. Keep your follow-up appointments. Follow the recommended treatment and management. Talk to your doctor before making any changes. And make it clear that the pain you are experiencing only started after your stroke.
Good morning. My name is Stephanie Souza. I'm the Assistant Clinical Manager of the Comprehensive Stroke Center at Rhode Island Hospital. And I'm going to be taking over the presentation at this point to talk to you a bit about available therapies and resources for mental health after traumatic brain injury. This slide gives you a list of different available therapies out there for mental health after traumatic brain injury. From what I've researched, cognitive behavioral therapy is the gold standard. And basically what it does is it changes the survivor's thinking pattern so they're able to recognize their thought processes or what their reactions are and help work through their feelings and change their mindset on how they're feeling. And that can be really helpful. But one thing I would like to point out is therapies are not a one-size-fits-all type of solution to mental health. You may find that one therapy that works for one survivor will not work for another survivor. You may find that a multitude of different therapies may work, such as medication and cognitive behavioral therapy or music therapy and talking therapy. It may be a different formula of therapies that will work best for each person. So when you're starting the conversation of therapies, you will want to keep an open mind and really have time to discuss with your primary care provider what's going on and what your feelings are, and maybe what's worked for you in the past in other scenarios or what you've heard has worked for other people. But keep that in mind. You want to have time to have these discussions and be aware that what works for one person may not work for another person. So really trying different things and seeing what formula works best for you or your loved one is really key in finding the best steps forward through your mental health. So on this slide, we're going to talk about what a survivor can do to help with their mental health recovery. And number one here is talk to your primary care provider. Get in, speak to your provider and see what options are available to you. What medications are they seeing working on the market? What therapies are available for you? And really just get that ball rolling, because it can take time for you to try the different therapies like we talked about on the last slide to see what formula of treatment works best for you. So getting in as soon as possible to get the ball rolling on this is really going to be beneficial. Seeking social support. So we really emphasize the importance of being in a group with other people who are going through similar situations as what you're going through. No one's situation is going to be identical to your own, but talking to other people who maybe have been where you've been or have family members going through what you're going through can be really helpful to get that social support. And we do offer a support group at Lifespan. You can also go on the American Heart Association and look up local stroke support groups or traumatic brain injury groups that are local to you. Some other important ones here: abstinence from alcohol and drug use. We find that we can use alcohol and drugs to kind of numb our emotions or our feelings, especially as a stress reliever, But what it really does is it can make our mental health worse, and it can cause more problems for ourselves and our bodies and our health. So really abstaining from alcohol and drug use is important. Avoiding caffeine because of what it does to your sleep and wake cycle. Your brain needs to rest, especially after such a traumatic injury as it's had. And when you're messing with that sleep-wake cycle, it really affects how well your brain can function. So making sure you're getting plenty of rest during this period. Reducing stress, that also will reduce the strain on your brain. And talking to someone you trust, because again, you need that social support. You need some opinions and, some encouragement to help you on your recovery, and that's important. And then take your prescribed medications and attend your therapies. This is important because sometimes the medications we get prescribed take a couple of weeks to work. So some people will say, oh, I was taking the medication for a week and I didn't feel any better, so I stopped taking them. Well, some of the medications take a couple of weeks to build up enough in your system to take effect. So have that conversation with your doctor and with your pharmacist and make sure you know when you should start to see a change before you change your medication or stop your medication abruptly. And then exercising and eating well, because that's great for our body and our brain. And lastly, here are some local resources local to Rhode Island that we thought would be beneficial to everyone. I would encourage you all to take a quick snapshot or jot a couple of these down, because what you need today may be different from the resources you need down the road in your recovery. So having these numbers on hand are always helpful. Some of note here: the Brain Injury Association of Rhode Island, Just Ask RI, the Rhode Island Office of Health and Aging. These are all great resources. You can go to their websites or call these phone numbers and get additional information. They may have their own support groups or support networks you can tap into, and really just great resources to have on hand as you walk through your recovery. Thank you all so much for tuning into our presentation. Karen, Melissa, and I would like to also thank Just Ask RI for having us. And just to reiterate, if you have any questions about a diagnosis or treatment for you, make sure to reach out to your primary care provider or your neurologist to get that ball rolling. And remember, be fast. Have a great day, everyone.
Well, thank you, ladies. That was amazing. A lot of information. I think you might have a lot of questions.
And
I
I just want to say, I know I told you, Denise, but that resource slide of resources that we put up, we're going to make that available to Denise, and she's going to disseminate it to everyone. So if you didn't get a chance to write it down or take a picture, you'll be getting it in your email.
And we'll add that to our website. We have a whole resource on our page, and that definitely will be added to it. So thank you.